he pursued his training in endoscopic spine surgery at Severance Hospital in Seoul, South Korea. He will talk about the evolution of endoscopic spine surgery.
Okay. Thank you, everyone. I'll present briefly about the evolution of endoscopic spine surgery. It is more than a half a century journey of evolution in concept, innovation, renovation, and techniques. It all started in 1963 when Lehman Smith was first to inject camopapine in the disc space. In the studies in early 1950 showed that in rat models, after injecting camopapine, the rat ear shrinked, and further examination of the specimen showed shrinkage in the cartilage of the trachea and joint. So the main concept at that time that if we inject camopapine in the disc space, the disc will shrink and will relieve the pressure from the nerves. They had a fairly successful result, and at that time the understanding of intradiscal decompression and the concept of intradiscal decompression started. Further followed by mechanical removal of the nucleus in 1973, Cabin used the Craig needle via posterolateral approach, and in 1975 Hijikata from Japan also described the percutaneous nucleotomy. They both reported the same result in the same time period independently. However, Hijikata's work did not gain much popularity because it was published in Japanese language and at a Japanese local journal. This is image depicts the Craig needle modified by Cabin, and in 1985 the automation or the nucleotome was invented by Gary Onek, and it's still actually its modification used today. They used to develop this device which has a suction and cutting ability, and in their article they reported that the weight of the disc is 5 milligrams they took. I don't know it holds significant in modern day practice. In 1986, Sherper was the first to use indigo carmine to stain the disc, and in 1987 Cabin introduced the working cannula and flexible forceps. And in 1999, he described the safe triangular working zone. This is from his original article depicting the safe triangular zone, which is bounded anteriorly by the exiting nerve root and posteriorly by superior articular process of the level below and medially by the thecal sac. So it was Michael Meyer who first termed the percutaneous endoscopic lumbar discectomy. He introduced also multiple angled lens scopes, and basically they will go through the same pathway in transforaminal use today. However, their technique was more of an in-out procedure. They will produce the discoscope, remove the disc part, and then produce the discoscope again to take a look. This is the image from their original article showing the remnant of the nucleus pulposus stained with carmine indigo. It was in 1999 when the real birth of endoscopic that we use today after the introduction of the YES endoscope by Anthony Young. This endoscope provided and overcome all the shortcomings of previous techniques. It has a working channel, it has a video recording camera, and a continuous irrigation and suction. And he was the first to introduce the continuous irrigation system, thus providing more visual clarity and homeostasis and aid in dissection. So with that, a new era began. We were able, after he described the in-out technique, to gain access to the ventral epidural space, and now endoscopic spine surgery has transformed from an intradiscal procedure to actually an intracanicular procedure. In 2000, another coincidence also, Thomas Haugland, he described the similar scope, and around the year 2004, he also invented the Tom Sheedy reamers to widen the foramen and to do foraminoplasty. And actually, it is still in use today. If we stop by the booth of Max Moore, we'll find it in the surgical set. So it was till the year 2006 when Sebastian Rutten introduced all endoscopic concept, and he was the first to describe interlaminar endoscopic surgery. However, at the same time period, for the third time in endoscopic spine surgery, Gun Choi also reported similar technique. In 2008, Gun Choi also introduced transforaminal burrs. So with the new approach, need for more efficient scope and shoes. So the first generation was for interlaminar endoscopic discectomy. Then in 2009, Rutan was the first to describe lateral recess decompression. And then we reached to the third generation endoscope, which has a wider working channel. And it can do central decompression and even interlaminar contralateral endoscopic lumbar phenomenotomy. So after achieving all decompression procedures, naturally endoscopic spine surgery turned their focus to endoscopic fusion, and it was Jacquet in 2013 who first described endoscopic fusion through transcambin approach. However, he used standalone cages and success rate was not high, reaching 50%. With the evolution of the technique now and almost in 2020, Ao reported a comparative result with the MIS TLIF. However, the endoscopic interbody fusion showed less blood loss and less operative time and faster recovery. I think this marked the most important step in endoscopic spine surgery when AO task force included endoscopic spine surgery in their MIS curriculum. Now it is a worldwide accepted technique for decompressive treatment. I wouldn't conclude my talk without talking about UBE, which was first presented by Abdul Ghaffar in named poster presentation lumbar disc excision by midline extradural endoscopy at the 68th American Academy of Orthopedic. And at that time, two Korean spine surgeons, Dr. Young Chol Choi and Dr. Om Jin Hwa, was first to implement it in Korea, where it developed. I will not spend much talk about UBE, since today we have among us a true pioneer and expert of the technique, Professor Dong Hwa Do. Thank you very much.
Thank you. I am honored to introduce Dr. Dong Ho. He is the head of Endoscopic Spine Surgery Hospital in Gangnam, South Korea, Harrison Hospital, and he is the president of the World UPE Society. 안녕하세요.
안녕하세요. Thank you for invitations. It's my honor to be here. So my name is Dong Hao.